And may I now request Dr. NEELAM Pushkar ma'am only. She is Professor of Ophthalmology and a very renowned oculoplastic surgeon at RP Center of Ophthalmic Sciences. And I request her to speak on orbital aspergillosis, a decade experience with Voricona.
Good afternoon, everyone. So today I'll be sharing my a decade long experience with voriconazole in treatment of invasive aspergillosis of the orbit. So we all know that fungal infections of the orbit, they come from the sinuses. The orbital cavity is surrounded on three sides by the sinuses. And but there can be other causes also, like trauma or hematogenous cause can be there, and the organisms are mostly aspergillus and rhizopus. So my topic today I'll be covering is the aspergillus infection. So it is potentially fatal if left untreated. And the commonest form of aspergillus infection that we see in the orbit is invasive aspergillosis, unlike allergic rhinitis and aspergilloma, which we see in the respiratory system. Concomitant sinus disease is found around 60 to 90% patients, and but the type of patients we see, they are usually limited sino-orbital or orbital invasive aspergillosis. And over say 2 decades of my experience, I have seen these patients mostly in immunocompetent patients, young to middle age, presenting with invasive aspergillosis. Though there are other risk factors also, like immunocompromised status or steroid or any kidney disease. Sorry. So the clinical presentation of invasive aspergillosis is usually, it's a very silent. There is hardly any inflammatory signs, and if it is there, it's of mild degree. And they have a chronic course, and usually they present with unilateral proptosis, and there will be some extraocular motility restriction, some inflammatory signs. Vision loss will not be as bad as we see in mucormycosis, and generally it is seen around 50% of the patients. And of course associated sinusitis also we see, but there are cases of purely orbital involvement also, which I have come across. So this is how the patient usually present, young to middle age, with quiet eye, with proptosis. And when you get the imaging done, you will see the sinuses, they are filled. And I'll come to the details of the imaging findings. So, but unlike in adults, very rarely we have also seen in infants with invasive aspergillosis. And if you compare with the previous adult picture, you will see that it has very fulminant look, and generally they are associated signs of inflammation. And if you palpate, you will find the lesions are really very hard all around in the orbit, unlike as you see in a case with bacterial cellulitis. So one can confuse that maybe this is bacterial cellulitis, but if you palpate, you will feel that it's really harder than induration, I must say. And they will not respond to your intravenous antibiotics. So this was a two cases we had reported, and this is one of the case infant where there was on FNAC only we diagnosed this as invasive aspergillosis, and you can see that only FNAC was done. This was immunocompetent baby, no sinuses involvement. So this is something which is difficult to explain, but this is how it is. So, and after 6 weeks of intravenous liposomal amphotericin B, you can see the response. So the response is usually, extremely good just by giving antifungals timely. So coming to the investigations, what we see on investigation, CT is the modality of choice. What we see is, ill-defined. That is very important. Ill-defined and hyperdense lesion, which can involve orbit, sinuses, maybe some other cavities, surrounding cavities. And bony erosion or defect is seen in majority of cases. And in immunocompetent patients, as I am talking about the localized one, the organism, the species is the aspergillus flavus, and in the immunocompromised patient, generally it is the aspergillus fumigatus. And because, as I said, the presentation is like a in months there is history of proptosis, so generally we'll end up doing biopsy, and the diagnosis is generally on the basis of biopsy. where we see the septate hyphae, 45 degrees angle, dichotomous branching. These are very specific, pointers towards this being aspergillus infection, obviously along with the granulomatous inflammation you will see. Then the role of biomarker, we know that for systemic invasive aspergillosis, it's the serum galactomannan, which really helps in, in even initiating the treatment in patients where you are not able to do a biopsy or take a sample. But if serum galactomannan is raised, the patient is started on, antifungal treatment just on the basis of that. So I'll come to a study which was done even in the, cyanoorbital disease. This is just to show the silver methamine staining. You can see the dichotomous arrangement of the filaments. And this is the fungal culture showing the yellowish green color colony. This is of aspergillus flavus. So I'll come to the voriconazole. Since voriconazole, almost it's been more than a decade that it has become standard of care for systemic invasive aspergillosis and even for the cyanoorbital diseases. So I'll come to the results, my own the studies which were conducted in our center. So as such, there are no guidelines regarding the duration of treatment. And serum galactomannan, one study which we conducted, after that at least I have started doing serum galactomannan in all our patients. The reason I'll come to. And the response to voriconazole, according to our experience, is around 80 to 90% patient, they respond well. And generally there is no need to do any sinus debridement or any mutilating kind of surgeries. So exenteration, as before it was considered, even in the apical cases, you can just give voriconazole. It really works. So now for past, I think 15 years or so, I am not doing any exenteration, not even orbital debridement in these patients. Biopsy generally is done by ENT people. If suppose they are not able to get the report properly or get the biopsy, then sometimes we do by orbital approach. But orbit, there is no need to really touch. So this is like one of the patients. You can see the sinuses, ethmoid sinuses. They are the commonest sinus to get involved. And see, after 3 months after debridement, even the orbital disease and the proptosis, everything has become almost normal. This is another patient where the predominantly orbital component was there and minimal sinus involvement was there. And you can see the proptosis, which resolved at 3 months follow-up. Some residual, scarred part of the thing will probably you'll see on imaging, but that doesn't always mean that you will have 100%, the thing will go away. It's not like that. That part of the orbital tissue which we see on CT, sometimes we feel that it's because of the some remaining fungal infection, but it's not like that. That is just some fibrotic, some soft tissue changes because there was infection there. So this was the first publication when I had joined. This was a 10 years retrospective study where we took the data from the pathology department. That time intravenous amphotericin B was the line of treatment followed. Only 2 patients in this series were given voriconazole. This is just, I wanted to over the past 2 decades, I want to show, 1-2 studies which we conducted and what were the, treatment outcome. So in this patient, if you see, 1 patient died and 6 patients underwent orbital surgery and 3 had, destructive procedure. Median follow-up was 20 months in this study. So this was the data from 1999 to 2009. Then this was another study which was conducted between 2012 and 2013. In this, we basically studied the role of voriconazole, because this was the time when voriconazole was used even for the systemic, invasive aspergillus infection. So in this, 10 patients were recruited. We all know it's a rare, disease, and rarely we come to see these patients. So 10 patients were included, 9 were immunocompetent. And all patients grew aspergillus flavors, and 90% patient they had good response to voriconazole. None of the patients they require any orbital debridement or any destructive procedure, though sinus surgery was required in most of the patients, and there was no recurrence with the mean follow-up of 5.8 months, which is a little short follow-up. But yes, that was the result. And this was the patient from, okay, another just 2 minutes. So this patient, you can see the response at 3 months. This is another patient. So treatment protocol is very much standard. We use intravenous for 2 to 3 weeks, followed by oral voriconazole. If patient is not able to afford oral voriconazole, then one can even start itraconazole. That also really works well. And this was a study which was conducted between 2017 and 2018, and this was on correlation of serum galactomannan antigen, and we correlated this with the response to voriconazole. 12 patients were included, and 5 patients had positive GMI. GMI is galactomannan index, and when we compared this with the response to treatment, we found that there was significant decline of galactomannan levels depending on the response, which correlated, absolutely correlated with the clinical response from day 7 onwards. The sensitivity was low because we know that it's a localized disease, and but the specificity was 100%. Controls were included in this particular study. So galactomannan, we all know it's a heteropolysaccharide cell wall component released by growing hyphae of aspergillus. So whenever you feel when to stop or when to start again, serum galactomannan should be advised. That is what I am following. And if this comes out to be positive, then one can start the treatment again, especially if you are thinking in terms of recurrence. So in this particular study, the duration of treatment I had kept a bit longer than the previous study. It was the average was 8 months. So as I said, that there are no standard guidelines for the duration. It varies from patients to patient. So the side effects were very few in my experience. Generally, it is the liver function which we have to monitor, and there is no harm in monitoring the serum levels of voriconazole also. So this is from the same study, and so the take-home message is that voriconazole works really very well. There is no need to do any debridement, as it can lead to functional damage of the surrounding structures as far as the orbit is concerned. But yes, sinus ENT surgeon can decide whether to debride or not. Serum galactomannan further studies are required, but at least I have started getting this done routinely in all my patients. Thank you.
Thank you, ma'am, for this enlightening talk on aspergillosis as a rare cause of bacterial of orbital cellitis. Ma'am, just to kind of summarize it, that when we keep this in mind as a rare cause of orbital inflammation, so are there any clinical pearls which can help us point towards aspergillosis, or is it mainly a radiological
See,
diagnosis?
if there is a proptosis, a long-standing, means months history, and yes, you can consider this as one differential, but on imaging, if it is a ill-defined lesion involving the sinuses, then that is the invasive aspergillosis is probably my first possible diagnosis. If it is ill-defined, hyperdense, involving the sinuses and the surrounding structures.
So we must keep it in mind in case we have a non-resolving cellulitis, and this should point us towards something which is atypical, and we can think of aspergillosis, especially if radiological features are suggested.
Yes, if it is ill-defined and there is in months there is history like chronic history, subacute history is there, and not very painful, and of course sinuses are involved, and this becomes the.
And it's heartening to know that voriconazole has really changed the outcome of these patients.
Yes, one should consider once we get the diagnosis, like pathologist Dr. Seema Kashyap is here. She is a senior professor with us, and she gives us the diagnosis, and we are then like happy that yes, okay, we now know what we have to do, and voriconazole is the.
I would say, ma'am, it's a wonder drug which has reduced the rate of incident.
Yes, that is the correct thing to use, but the problem is that it's expensive. But then I feel that there is no harm in starting. Once you give, 2-3 weeks of IV voriconazole, you can start patient on itraconazole. That also really works well, but I can't say because I haven't conducted any study on itraconazole, but that is also a good drug. And if voriconazole you feel is not available, even itraconazole one can consider. Thank you.